Good morning, everyone, and welcome to the Karmanos Cancer Institute 11th Annual Cancer Symposium. My name is Dr. Elizabeth Heath, and I'm Professor of Oncology at the Wayne State University School of Medicine. My colleagues and I are just thrilled to spend this morning with you addressing common cancer concerns and myths. We have a jam-packed agenda and really encourage all of you to take advantage of our sponsor and community booths and learn all that you can this morning about how to help yourself and your loved ones get the right information. After this brief introduction, we will be joined by Dr. Zachary Reichert, who's an assistant professor at the University of Michigan, and he's going to talk about a really important topic about cancer and how it runs in families. Then we will take a brief break and encourage you to visit our virtual booths, and we do so that your experience this morning can be enhanced. We then will listen to a fantastic panel full of experts talking about common cancer beliefs, when to question them, where do you find trustworthy information, and listen to these experts talk. We'll have another break and another time and an opportunity to talk to folks in the virtual booths again. And then we will hope that all of you will join us in the specific breakout sessions. There are very many topics. I know some of you would love to join more than one, but we hope that you can at least join one and learn with not just the physician, but also a patient advocate about their journey. They'll talk about new updates in what's happening in that specific cancer, as well learn about specific myths that perhaps is unique to that particular cancer. And then we will be joined by Dr. Mark Moyad, who's also from the University of Michigan, talking about natural supplements and where do they fit in our patient journey and care with regards to prevention or even treatment. I sincerely hope you take advantage of all the opportunities today and can join us for this morning. We'd love to hear from you about your experience even before the event today. So please fill out the pre-survey so we can learn more. And when you do so, you will be entered for giveaways, especially those from our partner at Mod Market. We also would like to thank our generous sponsors. Our platinum sponsors this year are Pfizer, Caris Life Science, and AbbVie. We also would like to thank gold sponsors who are Seagen and Ipsen, and then our silver sponsors from Genentech, and then our bronze sponsors from Taiho Oncology, GSK, Advanced Accelerator Applications, AstraZeneca, Lilly, and Sanofi Genzyme. We really could not do this meeting without your generous support. We also want to encourage all of you to recognize not just our vendors, but also community partners who are with us for the last 10, 15, even 20 years in educating all of us in the different cancer types and being a resource for patients and their families and our community. Please try to take advantage of them as well. And thank you for all of them for their support throughout the years. A special shout out to the members at the Veterans of Foreign Wars. They do a tremendous and generous donation to us, especially for prostate cancer research. And I'd like to recognize them specifically, as well as all of the other veterans that have served our country. Thank you so much for your service. We also would like to recognize the Detroit Rescue Mission Ministries. The Detroit Rescue Mission is an integral part of our community in Detroit. As you know, they have very many homeless shelters. And as we proceed into the cold winter months, please think of them and learn more in terms of how you can help their mission as well. I also just want to remind all of you to visit the Mod Market, again, our partner in this symposium. This is a tremendous organization that serve our community. And you can visit their website there. They have fabulous materials. All of their proceeds, portions of their proceeds, not all, portions of their proceeds will be donated to the Karmanos Cancer Institute. And you can do that, a t-shirt or these lovely candles. This is a tremendous organization as they employ young people with autism and other related challenges to really be a productive member of our community. Thank you so much to them for helping to sponsor and also support the Karmanos Cancer Institute. Remember, today our goals are to always focus on not just empowering survivors, but also supporting clinical trials, especially in cancer research, as well as sharing your voice. And I emphasize sharing your voice because we want to hear from all of you, especially during the breakout sessions. Come and be engaged and ask your questions so that they can be addressed by folks who are experts. And lastly, don't forget, we love social media as well. You could follow us at Karmanos Cancer, either on Facebook, Twitter, or Instagram. And we'd love for you to tweet out hashtag Karmanos Cancer Cares. That's been our tagline for many years. We hope you enjoy the day. And thank you once again for joining us. When I see you on the street.
Hello, my name is Zachary Reichert, and I'm a medical oncologist from the University of Michigan. I'd first like to thank the organizers and Karmanos Cancer Institute for inviting me to talk today. The topic of my talk is am I at risk of getting cancer if it doesn't run in my family? Here are my disclosures, and none of which play a role in today's discussion. But I think we need to go back to the title first, because really, what does run in my family mean? So we need to take a step back, and I want to share sort of an encounter I often have in my clinic. So someone comes into my clinic, they meet me, and I ask, have any of your family members ever been diagnosed with any types of cancer? The first response I see is thoughts, and then usually followed by a shoulder shrug because people don't really know a lot about their family. So we need to stop getting the thinking and the shoulder shrugs and move to having that information. So we need you to talk to your family about your family. We're going to talk about why that's so important today as we go through the whole talk. And also, typically things are always scarier when you don't talk about them. So I don't want to hear anybody about whispering the C word or not talking about cancer, because that just makes it more mysterious and it sounds scarier than it is. We have many things we can do for cancers today, and we have many people that want to help you. So no more whispering. Not talking about it doesn't make it not happen. This isn't Harry Potter. Because ultimately, when the family knows everything about each other, it empowers them to take care of themselves the best, and then the next generation the best, because they share that information with them. Because the more you know. So as a cancer biologist and as a physician, what do I mean when I ask a family history of cancer? So when we talk about family in general, we sort of think of anybody that shares the same family tree with you. But in cancer biology, we mean a little more specific. We mean that only those that are biologically related to you. So for example, if you have a brother or sister that share a parent with you, that's biologically relevant. Obviously, your direct parents and their siblings, so aunts and uncles that are blood related to your parents. Grandparents, any children that you have. Ultimately, it includes everyone except those that joined your tree through either marriage or adoption. And I think it's important to know that it's okay also if you don't know your tree, because sometimes you were adopted and you don't know anything about your family. But it's very different to tell your physician, my tree has no cancer in it, or I don't know much about my tree because I'm adopted, or we just don't know. Those are two different scenarios. And ultimately, we need more than just, oh yes, my aunt on my mother's side had a cancer of some type. We need a little more detail than that. So we want to know, what was that person's relationship to you, especially were they on your mother's or your father's side family? What type of cancer did they have? And also, had the cancer spread? How old were they when they were diagnosed with the cancer? And for cancers that they had and then that came back later, we want to know when they first were diagnosed with the cancer, not when it came back. Are they still alive? If not, what age did they die? And also, did the cancer kill them? This is a lot of detail, and it can be hard to keep track of it all. But that's what's nice about today is, of course, there's a website that can help. So here is a link to a website that's run by the Surgeon General and the National Institute of Health that you can go to, click on Create a Family Health History, and it'll walk you through how to make the whole history together. You can save it, you can come back to it later, but it'll ultimately walk through each of these steps with you, and then you can save and print out your full family history, and then you could share it with your doctors or anybody else you want one to. So this might be some good homework to do over Thanksgiving this year. Because ultimately, why is it important to know your tree, both for those who do and do not have a family history of cancer? So for those with a family history of cancer, your risk of developing a cancer may be higher. So for example, and this is important for people that have people of the same gender with cancers. So if you're a woman and your sister has breast cancer, your risk is double for developing a breast cancer compared to the general population. If you're a man and a sister has breast cancer, your risk of developing prostate cancer increases 20%. So it's important even for those that are of a different gender than the person who had the cancer. And it's also important across generations. So if your brother or father had prostate cancer, your risk is 60% higher than the general population. And finally, it's also additive. And what I mean by that is if you had a brother and a father with prostate cancer, your risk is 75% higher than the general population. So ultimately, we need to remember that for those with a family history of cancer, that cancer screening still saves lives, even for those with a family history of cancer. So get your mammograms, your colonoscopies, your PSAs checked. And again, remember that cancer doesn't care about COVID-19. We can take care of you safely, both at Karmanos and the University of Michigan. And we need to keep on top of all of these screening measures that are getting delayed with COVID. We're here to help take care of you safely in the new world that we're living in. I think it's important, though, to note that for those with a family history of cancer, that not all of you will get cancer. Depending on the type of family risk that you have, depending on the number of people that have a cancer, it's very different, and it's definitely no guarantee that you would get a cancer. Most people actually don't. And you can also decrease your risk of developing cancers. We're going to talk about that a little bit later when we talk about some of why do people get cancers at all, because that's the easiest way to understand how we can try to decrease that from happening. Also, you and your doctor are not alone to figure all of this out. For those with a family history of cancer, a whole medical discipline exists to help you with this. That discipline is medical genetics, and it contains many physicians and practitioners and genetics counselors. They may meet with you before testing is even ordered to go over how it could affect you and your family. They may go meet with you only afterwards to go over the results to review whether they were positive, negative, or something unclear, and go over all those details with you. So again, you're not doing this by yourself. but you need to talk to your cancer team about it. Because ultimately, people need to ask their doctors, should I be tested for any cancer conditions that could run in my family? If you have cancer, that's a great question to ask your cancer doctor, because a lot of cancer doctors now are comfortable talking about genetics and inherited things because we test for these things to help take care of not just the patient, but also their whole family. Because the best way to manage a cancer is to try to prevent it from happening or to take care of it before it becomes more of an issue. So let's get back to the main question here of those without any family history of cancer. So again, this means you took a really good family history, you talked to a lot of your family members and got as much information as you could. We don't just assume that there's not because we haven't talked about it. So the first part of that is when we look backwards is people used to die of lots of other things. So you had to live long enough to develop the risk and the cancers that you could have had. So a great description of this is with heart disease. So heart disease has historically been one of the number one killers for many, many years, and that such that people would die from their heart disease before they ever got old enough to develop the cancer that they were at risk for. But we're doing such a better job with managing heart disease now, both for men and women. So if you see here the dark line, this is the number of deaths per 100,000 people for men. And from 1980 to 2010, it's gone down a lot. This dotted line is the risk of death from cancer, which thankfully is going down, but not as quick as heart disease. And for many states have actually already switched, and cancer can be the leading cause of death. And when we look for women, this dashed line is the risk of heart disease. And this bottom line then is the risk of cancer. And in 2010, that already switched, where cancer became the leading cause of death for women in the United States, more so than more so than heart disease. So again, the generations before us may not have lived long enough to develop the cancer they were at risk for. Also, we have to remember about healthcare engagement. So if your family members never saw a doctor, they were not being checked for cancer. We need to take care of everyone in our family. So not knowing is not having it. It's just not knowing. And then the biggest take-home point we have to remember is that for those people who are diagnosed with a cancer, most of them have no family history of cancer at all. Only about 10% of all cancers have any family component with them. So how do we then manage these risks, both for those with the family history and without, so we can best take care of ourselves? Some of the talks today are going to go over that, about good, healthy lifestyle and such, but let's touch a little bit on what develops cancer, how does cancer happen, and just some of the broad strokes of how we can manage that risk. So we have to remember that cancer is a disease of our DNA, sort of like how diabetes is a disease of sugar in our body. Cancer is a disease of our own DNA. This is called genomics, which you've actually talked about here at other Karmanos Cancer Days. So when we think about DNA, DNA is kind of like our body's blueprints. Each cell in the body has its own set of DNA. Most of them are all the same, but over time they can change, which we'll discuss. But the DNA in each cell tells it how it should develop, how it should interact with other cells in its environment, when and how it should grow, and also when it should die. The blueprints can develop typos and mistakes. So some typos are just part of the normal process. You try copying 3 billion letters, such that the cells actually have editors in them that check the DNA, check the blueprints to try to fix any typos that happen before the cell splits and makes more cells. And that's because if the cell doesn't fix the typo, when it makes a new cell, that new cell will contain the typo also. So over time, these typos, if they keep going and each time it goes, we get a little more typos, a little more typos, and a little more typos, those original blueprints can change from looking like something good to something bad, like a cancer cell. So because this happens over time and the typos are accumulate, because not one typo can make a cancer. It takes many, many typos. That's why cancer also happens in older people, because their body has had more time to develop those typos. And when we look at the people that have a family history of cancer or cancer that they got from their parents, that risk, they actually find that it's not the typos that they have the problem, it's the editors. So people with cancer that runs in their family, if they have a gene that's broken or a part of the DNA that's broken, it's because their editors are not as good. So those typos that happen either with the cell itself on accident or from something outside the environment doesn't fix the typos well, so they can get cancer easier and also at a younger age. Hence why we ask when people develop cancers in a family, we always like to know at what age they developed the cancer so we can try to guess if their editors are broken. So the cells make some errors on their own, but how we live our life can also make more typos happen. So the biggest one that we can all help manage with each other is smoking. Smoking damages the cells in the lungs and makes lots of typos happen in the lung cells. Those editors will try to fix it, but if we keep smoking and keep harming those cells, the risk of the typos happening enough to develop a cancer raises. And that affects not just lung cancer, but bladder cancer and many other cancers in our body. Obesity also increases the number of typos. Sun exposure directly damages the skin and can cause damage to the DNA and thereby makes the typos itself. And then also hazardous chemicals. These aren't as much of a problem nowadays with better work environments and such, but also people, especially in the military, may have been exposed to things like Agent Orange, and the people in old homes may be exposed to radon. So those are things that we can have checked in our house and in our life to try to keep ourselves as safe as possible. Because we need to remember, though, that we can't stop all the typos because some of them just happen naturally in the cells themselves. But we can give our editors the best chance to fix those blueprints by not making more typos happen. So to stay healthy completely, we need to make sure that we take care of ourselves. We have to have a healthy diet, which we'll talk more about today at other talks. Exercise is important. Not smoking or stopping smoking if you already are. Even if you have a diagnosis of cancer, stopping smoking has been shown to help people live longer even after they've been diagnosed with cancer. So it's still always important. We need to be safe at our work and at our home. We need to wear sunscreen, all those things our moms used to bug us about. And ultimately, we need to see our doctors. Because if we don't see our doctors, we don't know what's happening. And so we need to make sure that we're all staying on top of our cancer screening and our general health. And then also, we need to take care of each other. For our families, we need to talk about cancer. In our communities, we need to talk about cancer. Because if we don't talk about it, we're not going to do anything about it. We need to help and support each other to make good life choices. Nothing can help someone stop smoking like somebody else stopping with them. And then we can remind each other about cancer screening and seeing the doctor. Not everybody always keeps track of themselves the best, but sometimes a little reminder or a loved one to go with them to the doctor to make sure nothing is missed can be really helpful and really important. So I want to take a step back and summarize a lot of what we've been talking about during this talk about both cancer risks for ourselves, cancer risks for our family, and for those without a family history, still critically important for you to think about cancer. And for those that don't have a family history that came to today's Karmanos Cancer Day, It's a great thing to be proactive on your health already. And I'm glad that you're here. And I'm glad you're doing everything you can to keep you and your family healthy. So in summary, you need to know your family tree and share it with each other. Talk about it, ask each other, ask all those details I mentioned. Use the website to help walk you through these things. We can't do it by ourselves. It's always best to do it with each other. I love having this meeting always during November because it's a great thing to do over the Thanksgiving. Share this family tree with your primary care doctor. If you've never been diagnosed with cancer, let them know what cancers may run in your family. If you have cancers that run in your family, they may check you for cancer differently than everybody else. It's important that they know. If you have cancer, share that family tree with your cancer doctor. A lot of cancer doctors are trained now because of so much of our care to help people with understanding inherited risks or family tree risks of cancers. So a lot of us are very comfortable and want to talk about these things with you. And for those of us not as comfortable with it, we know that we can lean on our medical genetics teams and our genetics counselors to help us. Because I love taking care of my patients, but I love helping them take care of their families such that we never have to have them have cancer in the future to begin with. The best cancer is one that we prevent. The second best cancer is one we take up before it becomes much of a problem. Ask your doctors, and this is all doctors, not just cancer doctors, should I be tested for any family cancer syndrome or family cancer conditions? They'll need that information from your family tree, but even if you don't know your family tree, and you just need to ask because it's something that still should be talked about, even if you don't know your tree. Because some cancers, if anybody has them, we check for these things no matter what, even with no family tree of any cancers. So we just need to make sure we have the discussions. And if you don't know your family history or there is no cancer in it, still work with your doctors to check for cancer before it becomes a bigger problem. I emphasize this again in the middle of COVID. COVID's not over yet, but we can help take care of each other, both for COVID, but also for cancer. And we need to be on top of our cancer screenings. Your primary care doctor can help. If they're not sure what's available, call the hospitals, ask them how they're keeping everybody safe to do their cancer screenings. We cannot lose all the ground we've gained by managing cancers earlier because of the ground lost with the time from COVID. We're ready to see you, we're ready to take care of you, and we can take care of you safely. Finally, talk about all of these things. For you that are here, I'm so glad you're here. Talk about it with your family. Tell them what we talked about today. Share with them the information or the slides, so then they can take care of themselves well and they can take care of each other well. So I've mentioned a lot of websites, I've mentioned a lot of things, so I wanted to put them all in one place. So you can see the first website on the top is the NIH, that's the National Institute of Health. It's a wonderful body that helps teach people how to take care of themselves and shares a lot of information about cancer. And you can see their website here. This is the website for the Family History Form. Below is the CDC website. This is the Centers for Disease Control. They have information about family cancer risks and family understanding. And the American Cancer Society has a long description of also how our family risk affects you, and also for those who don't have a family history. So these are great websites to visit to get more information for you, and for other people that may have questions, please share it with them. Because again, we're all in this together, and we're all here to help take care of each other. I hope during this talk you've thought of some great questions, maybe written them down, because we're going to have a great time to answer some questions in the group discussion in a little bit. Thank you all for your attention, and I hope you have a wonderful day at the Karmanos Cancer Institute Cancer Day today.
Good morning and welcome to the panel entitled Journey to Cancer Knowledge, a discussion of common cancer beliefs, when to question them, and where to find trustworthy information. I'm your moderator for this panel, Dr. Catherine Bach. I'm an associate member of oncology at the Wayne State University College of Medicine and a scientific member of the Karmanos Cancer Institute. My research is on cancer, focusing on reducing racial disparities in cancer incidence, aggressiveness, and outcomes. And I work very closely with our cancer advocacy program, which facilitates advocate and survivor engagement with Wayne State and Karmanos cancer researchers. So as the title implies, the goal of this session is to discuss myths and beliefs related to cancer that may cause fear or distrust that result in delays or avoidance of cancer screening or cancer treatment. So we hope that the knowledge and experiences that you hear about from our presenters today will empower you and those you care about to overcome any beliefs that may be held about cancer that are getting in the way of staying healthy. So it's my great pleasure to introduce your first panel presenter, Mr. McKinley Walker. Mr. Walker is an active cancer advocate at Karmanos Cancer Institute, who, among other activities, partners with Karmanos researchers to ensure that our focus remains on effectively improving the lives of people affected by a cancer diagnosis. And I refer you to the program for more details on each of our speakers. Mr. Walker will address the important question, when should I question my beliefs about cancer care? So I take you over to Mr. Walker.
Hello, everybody. I'm real thankful to be here. My take on this is I'm going to do an analogy on this. And it's about something that happened when I was a child. Everybody has seen The Wizard of Oz. And at my house, we had a television that was black and white. You know, the old antennas, you had to be the antenna wrangler and the remote, you know. And it was a wonderful movie to me in black and white. And then one day, Mrs. Kendra lived down a street from us. Her husband was a TV repairman, had his own TV shop, and they had a color TV. And she had this little party and invited all the kids down, and we watched The Wizard of Oz. And trust us, it was a great movie because they had flying monkeys, okay? And something happened that changed everything for me. As Dorothy asked the good witch, how do I get to the Emerald City? She says, follow the yellow brick road. And when that happened, this black and white movie all of a sudden burst in color. Well, to my surprise, I never knew that this movie was in color. So the point I'm trying to make is sometimes that journey is very short, and that it takes just one person to change your point of view, which was Mrs. Kent. Now, the movie was great in black and white. It was even better in color. So what I'm saying is that really changed my belief about this movie. And it changed the way I view things. And it also got my curiosity up. If this movie is it's got some secrets, how about the next movie? So I'm coming at this as a person. I'm not a medical person or anything like that. But there's so many myths and wrong information out there about cancer and the causes of cancer. I really challenge that. When you call something a myth, you are already saying that what the person is saying is invalid. It doesn't mean anything because it doesn't have any validity to it. I'm saying like this, those words shouldn't be used, period. Everybody has a story. Everybody has information. And I think that the lack of information is the most critical thing that we should look at, you know, and that's my job, is to find the information and give it to the people who need it the most. I love the movie. I love the ending. And you got to really look at this movie. I mean, there's people on the journey trying to get help for a problem that they have. And they're going to go to Oz to do it, you know. And there's a meaning towards our humanity. the drive to do something better, you know. I wrote down all these notes and everything of how I'm going to do this, but I'm just coming from the heart with this. You know, if it wasn't for Mrs. Kent, I don't think I would have been able to see that movie. For one thing, we couldn't afford a black and white a color TV. The signal that came in was kind of weak. And if we did have a color TV, there wasn't that many programs that were in color. So all these limitations stopped me from seeing the movie the way it really should be. And I think that's happening with patients out here. They don't see the colorful picture that is out there. And it's my job to give them that information so they can make a decision about their cancer care. I leave it to the doctors, researchers, all you wonderful people who got the answers. I don't. All I can do is try to spread this message that there is help out there for you, you know. And as far as myth, I could start one right now. Let's say here we are in Detroit, and the ambulance picks us up because we're sick. And we go over the rainbow onto the yellow brick road, going to Emerald City General Hospital, where we will be taken care of by Dr. Oz. That might work. So with that, I'm just saying that we need to give the information out to the people that are there. We had an event here down at Ford Field, men's health event. And there were so many people down there. And it just impressed me that people are really trying to get the information they need for the healthcare. And sometimes you don't, when you bring people down there, just tell them to come along with you. And what surprises me is that the people that you bring with you all of a sudden gets involved because they get into this situation where they see what can be done. I love Karmanos for this. I love being involved with this. Like I say, I'm not a doctor. I'm not even close to it. I'm just a guy that just want to help. So that's my take on things. And with that, I'll pass.
Okay, thank you so much, Mr. Walker. I really appreciate that perspective that just because you believe something that isn't true doesn't mean it's a myth. You just haven't been able to see it in color yet because you don't have that information. It's not a myth to you that the movie is in black and white. It's a plain fact that it's in color and you just didn't know it. And so I think sometimes, like you said, using myth is blaming the victim. And I really appreciate you pointing that out, not just today to us, but to cancer researchers at Karmanos in general over the past year. Has been really helpful. Our next presenter is Dr. Isaac Powell. He's a professor of urology at Wayne State University School of Medicine and Karmanos Cancer Institute. Dr. Powell is not only a practicing urologic oncologist and distinguished prostate cancer researcher, he's also a cancer survivor and advocate. And I again refer you to the program for his many accomplishments. And Dr. Powell will now address the common belief that cutting into cancer will cause it to spread. Dr. Powell?
Does cutting into cancer cause it to spread? It is very difficult and rare for cancer to spread because of cancer, and doctors take steps to prevent this from happening. We've had many advances in the use of equipment during surgery. We have better lighting. We have lighting within the instruments. We also have robotic surgery, which allows us to see the surgery better. The open surgery can be seen better and felt better with the improved lighting. We have detailed imaging tests before and after the surgery, such as a CT scan and MRI that will help define the cancer. We have medicines to prevent the spread, adjuvant therapy, and I'll talk about that later. Doctors also are very careful during surgery to prevent situations where spread could be possible. Cutting into cancer does not automatically cause it to spread. Why not? Because of the concept of the seed and the soil, which is a concept that was proposed in 1889, the seed being the cancer cell, the soil being the tissue surrounding the cell, which we now call the microenvironment. The seed cannot grow without the soil, and most people are certainly aware of that. So this slide here shows that a cancer cell within the blood vessel is how cancer cells spread to other sites. And here you can see the tissue of the primary tumor and the cell going into the blood vessel and through capillaries spreading to other sites. This is a place where the tumor may be cut and the cancer cells may get out of the blood vessels and fall into the cavity where the surgery is being done. But the cell cannot grow unless it's in the appropriate specific environment in which it can grow, which shows here the cell invading into the tissue of a distant site, not the primary site, but a distant site. And so, again, this shows the cell. And around the cells is the soil. This we call the microenvironment. This is what stimulates the cells to grow and to change in their characteristics. And this is where a cell can enter the blood vessel and spread to other sites. This would be a distant site here. But again, this is the soil in which those cells can grow. And it has to be specific to the cells that have spread. It cannot be just any tissue, but specific to those particular cells. And that's how it spreads. But again, if the incision is through the tissue and only the cells escape, the cells cannot grow unless it's in its appropriate surrounding soil. What is adjuvant therapy? Adjuvant therapy is often used after primary treatment, such as surgery, to lessen the chance of the cancer coming back. Even if surgery was successful at removing all of the visible cancer is a key word here, microscopic bits of cancer sometimes remains and are undetectable with current methods. So such as a cell may have escaped the primary tumor that I showed you through the blood vessels to other sites before we remove the cancer that we can see, it may recur. Also, if we accidentally scrape the edge of the cancer and leave some cancer cells with the tissue, with the soil left in place, we can often see that on image studies, or the pathologist can tell us that there is an edge here that is cut and cancer cells may be left. In that case, we would again use adjuvant therapy. Let me go back. Adjuvant therapy can include radiation therapy, chemotherapy, or immunotherapy. Now, another myth. Cancer spreads when exposed to air during surgery. In fact, there is no scientific evidence that cancer spreads because it has been exposed to air. Cancer rarely spreads as a result of surgery. In conclusion, the seed, the cancer cell again, requires the soil with the fertilizer, the microenvironment, which contains stimulating cells to make the cancer cells grow in the primary tumor and in metastatic sites. Cancer cells cannot grow alone if the blood vessels are cut and cancer cells are spread at surgery. If the soil required for growth is left after surgery with cancer cells, then the adjuvant therapy, which is additional therapy such as radiation therapy, chemotherapy, or immunotherapy, is necessary to prevent the cancer recurrence. Cutting into cancer does not automatically lead to cancer spread, and cancer does not spread when exposed to air. Thank you.
So thank you very much, Dr. Powell, for discussing the belief that's out there that we hear a lot among the community that cancer can spread when it's cut into or exposed to air. So we really appreciate the science behind why that is mostly unfounded, but where we can see the seed of truth that led to that belief spreading. So our final presenter is Dr. Lauren Hamill. She's an associate professor of medicine at Wayne State University School of Medicine and Karmanos Cancer Institute. Dr. Hamill is a leader in the field of behavioral oncology, and one of her many areas of expertise is the role of implicit and explicit bias in cancer care. And that's what she'll be addressing today. But I do encourage you to refer to the program for greater detail on her background and really important diverse research interests. So over to you, Dr. Hamill.
Thank you, Dr. Bach. And thank you everyone for having me here today. I always enjoy being able to present at this symposium. So as Dr. Bach mentioned, my research focuses on patient and healthcare provider communication, But I also examine different attitudes, including implicit bias on the part of physician, but then also attitudes on the side of the patient as well. And so today I'm going to give a really brief talk on how bias and those other attitudes influence cancer care with a focus on patient-provider communication. So my research is prompted by the well-established and persistent disparities we observe in cancer care. So for example, we see that compared to white patients, Black cancer patients are less likely to receive treatment for several types of cancer. And if they do receive treatment, it's more likely to be delayed or non-standard. And these treatment disparities are likely leading to cancer mortality disparities, which is 12% higher for Black women compared to white women, and 19% higher for Black men compared to white men. Now, of course, there are a number of contributing factors to these treatment disparities, and I focused on the two that are highlighted on this slide: patient-provider communication and patient-provider attitudes. So when you think about clinical communication, there's the provider. In this case, we often talk about physicians or oncologists, and there's the patient, and then there's the interaction that they have. Now, patients and providers are both humans and subject to all of the biases and attitudes that humans develop over a lifetime. Both have their own backgrounds, their experiences, their attitudes, their judgments, and those likely influence how they communicate with one another, the perceptions they have of one another, and the decisions that they make together regarding the patient's cancer care. Now, when I talk about attitudes and perceptions that might influence how patients and providers communicate, I'm talking specifically about implicit or non-conscious bias on the part of the physician. And then for patients, we like to examine a few different attitudes. First is a suspicion that medical treatment might not be as good for certain racial groups, trust in physicians and medical institutions, and then also previous experience with discrimination, maybe in healthcare, but maybe in other areas like employment or criminal justice or education. So to kind of illustrate, kind of how I examine these attitudes in the communication, when you think about it, you've got a clinical interaction. You have a patient, you have a provider. The physician might recommend treatment, but a patient may decide that the treatment benefits are not worth the costs or risks of receiving that treatment. The physician, the patient may want treatment, but the physician may decide that the patient is unlikely to adhere to, tolerate, or benefit from that treatment. And, these kind of competing attitudes or these competing, desired outcomes could be especially influenced by racial attitudes in, interactions where the patient and the physician are from different races. And, I want to point out too that treatment decisions that are driven even in part by any kind of race-related attitudes are preventable racial healthcare disparities. So if a physician has a bias that maybe he or she isn't even aware that they have, if that's influencing a decision, that's a disparity. If a patient is concerned that the care they're going to receive, even if the suspicion that they have is, completely logical and understandable, if that's getting in the way of quality care, that's a disparity that we can, address and try to remove. Research has shown, including research that we've conducted here at Karmanos, that clinical communication with Black patients is almost invariably poorer than communication with white patients. So, for example, this slide breaks down some very, objective differences in clinical communication that we see with Black patients. So, on the physician side, we see that physicians tend to provide less information to their Black patients compared to white patients. They're less patient-centered, they're more verbally dominant, and more contentious. And then on the patient side, we see that Black patients compared to white patients tend to ask fewer questions, participate less in their decision-making, and also leave their clinic visits with less understanding of their diagnosis and treatment plan. And we also see that visits with Black patients are on average shorter than visits with white patients. Now I'm going to move on to some research that's investigated how physician bias in particular has been shown to influence communication with Black patients. So I just showed you kind of a breakdown, a summary of what clinical communication looks like for Black patients. Now, we're making some assumptions that it could be due to certain attitudes, but of course that requires some research. But what we've seen in studies that have examined levels of implicit bias on the part of the physician, we actually see some documented differences. So physicians with higher implicit bias tend to see their Black patients as less trustworthy, less educated, and less likely to adhere to treatment recommendations. They provide less aggressive treatments to Black patients and are more verbally dominant in clinic visits with Black patients. And also, they're perceived by their Black patients as less patient-centered and trustworthy. And I highlighted that last point because implicit bias is by definition something that operates outside of our awareness. So the individual might not be aware of the bias that he or she holds, but the patients that they're interacting with are noticing or picking up on something, which is why it's so critical to keep investigating this phenomenon. I also want to speak briefly about patient attitudes, because of course we're talking about an interaction with two people, at least two people. We see that patients that have negative racial attitudes, so again, maybe high suspicion, low trust, experience with discrimination in their past, they tend to view physicians and medical institutions as less trustworthy, but they're also less likely to engage in certain health behaviors like cancer screening, genetic counseling and testing, less likely to adhere to treatment recommendations, and also less likely to fill prescriptions. So the reason why I bring this research up is to document that, racial attitudes exist for both patients and physicians. Not to point blame at why these attitudes exist. As I, stated at the beginning, they're often a result of the culture that you're brought up in, logical reasons for the reactions that we have, but that they might be preventing, quality health outcomes for our, a diverse patient population. We see these attitudes persist, and they're influencing communication and in turn outcomes for patients. So now that I've gone over the problem briefly, I'm going to go over some potential solutions and some of the solutions that we've tested here at Karmanos. So potential solutions for these issues have been described at a few levels. We have clinic-focused approaches, encouraging physicians to individuate, to see their patients as unique people and not a representative of a group, encouraging perspective taking and cultural humility, encourage training and use of patient-centered communication skills. On the patient side, designing interventions to help empower patients and their families by encouraging active participation in doctor's visits and in healthcare relationships. And then, of course, at the highest level, addressing structural racism, putting efforts in place to promote anti-racism training, hiring and promoting a more diverse clinical and administrative staff, and engaging the surrounding community in meaningful ways to help build up that trust that we see might be lacking in some areas. So I wanted to highlight these here to demonstrate that researchers at Karmanos have been working on these particular solutions. Encouraging training and use of patient-centered communication skills isn't just helpful for mitigating bias. It's helpful for a number of things for patients. Empowering patients and their families to encourage active participation. We spend a lot of time designing and testing informations to do that. And importantly, we do so by engaging the community that we're in. So it's not just researchers sitting in our offices kind of coming up with different ideas, but really looking to the community to help solve this problem. So this slide, as I kind of come to the end, is just to show you some of the interventions that my colleagues and I have spent a lot of time working on as ways to improve the patient-centered part of cancer care with a focus on communication, empowering patients, and doing so while engaging our community as a way to mitigate the negative influence of those biases. And one of those interventions, and I bet a lot of you in the audience have either used them or maybe helped us build them, are question prompt lists, or QPLs. And we've had a lot of success. They're really simple tools. They're lists of questions patients might want to ask. It helps empower patients to participate actively. It improves that kind of active participation on the part of the patients, prompting more questions, stating more concerns. And the reason why we want to do that is because research has shown that the more actively patients participate in their own care, the more information they get from their providers, we see improvements in the quality of treatment recommendations and decisions made. We see an increase in the number of topics discussed. And also we see improvement in outcomes for patients, both psychologically and physically. So we've tested a number of these in our cancer center with some really encouraging findings. We see that patients act favorably to these types of questions lists. We see that questions do not add a significant amount of time to the doctor's visits. Of course, we're in our clinics and providers are, always busy and fully scheduled. So what we don't want to do is add extra time to those interactions. And we've designed these interventions and these tools so that they don't. But most importantly, we see that they're increasing patients' participations in their doctor's visits. We're observing more questions asked, we're seeing more assertions made, and more concerns voiced on the part of the patient. And we're continuing this research as well and develop these interventions to make them more sophisticated, more accessible, easily distributed. But as I end, I just want to say, of course, tools and interventions are a great way to improve. But a final thought just on how kind of attitudes influence how we communicate. And, there's really not a way to rewire us. I mean, there's a campaign or a marathon involved. You can't take a pill, you can't have a shot to vaccinate yourself. But really what I think is probably a more helpful strategy is creating an environment where biases and attitudes are less likely to be activated. Individualizing the patient, individualizing each other, doing what we can to reduce distractions, which is no easy task in the world that we're in. We all have phones, we're all in front of our computers. We always hear our emails pinging and our text messages pinging. But, removing those to be able to focus on the interaction that we're having, providing time for our patients to speak so that they can get their concerns voiced, and also allowing ourselves to question our assumptions. If we have a reaction to someone, taking a moment to think, why am I thinking that? Am I thinking that because I actually have some evidence to suggest that? Or maybe is it because of a bias or an attitude I hold? As I finish, I just want to put my email address at the top of this slide. If anyone has any questions in the future, please jot that down. I'm very happy to respond to any questions or ideas anyone else has in the future. So thank you.
So thank you so much, Dr. Hamill, for kind of bringing together not just the problems that we have related to bias, but also to solutions, and particularly for this audience, solutions for patients and their family members and loved ones who are going through a cancer journey with them. And so Mr. Walker brought up to me in a sidebar chat some other beliefs that he's experienced growing up and living in his life. And I was hoping that maybe Dr. Powell and Dr. Hamill could talk about ways that patients could incorporate any beliefs or concerns that they might hold into their care, that there are no stupid questions. It's okay to be wrong and to get the correct information so that you can be empowered to advocate for yourself or your loved ones with your physicians. So Mr. Walker, you had some comments?
Yes, one of the things that really irks me and a whole lot of people I've talked to is the waiting time that you have when you go to see a doctor. It's like your time is not valuable at all. I had a doctor tell me that. He says, well, you don't see me enough that it should be a problem. But he had me waiting for over an hour to see him. And what the people out front told me is that he was on his lunch break. Okay. Well, I had to go to work that day. So now I got to travel halfway across town to get back to my home to get dressed to go to work. Our time is just as valuable as the doctor's. And I think they should respect that. And I understand that there's a lot of patients. There's things that I don't know about that's happening. But that's one thing they need to address. And Dr. Hamill, everything that you showed was just unbelievable. I love it. Thank you.
All right, well, thank you. We're almost out of time. Dr. Powell, do you want to give our last statement for the session?
Addressing Mr. Walker's question, it is a systemic problem. I'm not sure how to change that because there's so many things outside of the doctor seeing the patient that has to be covered, insurance issues, whether you have other comorbidities, and all those factors enter into it. And we try to, at Karmanos at least, to eliminate that or shorten that process as much as possible. But I certainly appreciate that because I've been a patient as well as a provider, and I've gone through all of that you've described. I'm not sure how to solve that problem. So I just wanted to address that issue. Beyond what I said about the cutting through tissue and the air hitting it, I have no more comments than that. I think I hope I described it such that the layperson can understand what I'm saying.
Yes.
Great. All right. Well, thanks, everyone. Unfortunately, we're out of time, but I hope people feel empowered to go look for the resources and information to look up information that will be helpful at their level to help on their cancer journey. And with that, I thank our speakers again. And following this session is a 15-minute break. And I encourage the participants to interact with the virtual booths during this time. And then following the break, we'll have our breakout sessions addressing updates in cancer advancement. So thank you and goodbye.
Thank you.